to the Joint Standing Committee on Health and Human Services. This morning we'll be going through, we'll be hearing from Dr. Shaw for about an hour and then spend some time working on the DHHS budget. This afternoon we'll hear three bills being introduced, so that will fill up our afternoon. If you want to watch, in addition to listening, you can go to the YouTube channel, which can be found at legislature.maine.gov and look up Health and Human Services Committee. That'll take you to a link where you can watch. Everything's recorded, so if you can't stay for the whole thing, you can come back and watch later on. We're making our way through the technology and things are going better, but we may have some glitches along the way, so please be patient and bear with us. I have remembered to turn off my phone today. That would make it notable. Please leave yourself on mute. Dr. Shaw will be addressing many of the questions coming from our constituents, as many as he can. We submitted some from the committee earlier, and we'll save time for additional questions at the end, but given the volume of questions, we may not have time to get answers to everything, at which point we'll ask the department to get back to us either through another visit with Dr. Shaw or by hearing from Director Bogart, who has been an excellent conduit for answers. So we'll depend on you two to get back if we don't have a chance to go and get answers to everything that gets asked, but we'll save some time at the end so people can ask. So why don't we do introductions, and we'll start with Representative Zager.
Good morning, everyone. I welcome Dr. Shaw. Thank you, and thank you, Mr. Chair. Sam Zager, to represent District 41 in Portland.
Representative Lemelin.
Good morning, Michael Lemlin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover.
Good morning. Welcome, Dr. Shaw. Holly Stover. I represent House District 49, including the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Senator Baldacci.
Hi, good morning. Thank you, Dr. Shaw, for being here, and thank you for the great work you're doing in the greater Bangor area. Cross Insurance Center is being a real success. I represent the city of Bangor and the town of Herman, and I am a state senator from District 9. Thanks.
Representative Perry.
Good morning, Dr. Shaw and people. I'm Representative Perry. I represent House District 140, which includes Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
And I'm looking for Representative Griffin, but I don't see her here yet. Representative Connor.
Good morning. Thank you, Mr. Chair. My name is John Connor, and I represent House District 58, which is part of Lewiston.
I was a little sensitive there because I skipped Representative Griffin yesterday. So, Representative Craven.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
And I don't see Representative Madigan. So Senator Moore. Oh, there you go, Representative Madigan. There.
I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Representative Javner.
Good morning. I am Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington County.
Senator Moore.
Good morning. Good morning, Dr. Shaw. I was thinking this morning when I was driving in, has your wife seen a moose yet since you all arrived? I couldn't resist asking that question. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan as well.
Representative Meyer.
Thank you, Mr. Chair. Good morning. My name is Representative Michelle Meyer, serving Southern Maine's House District 2, which is parts of Kittery and South Berwick and all of Elliott.
And I'm Ned Claxton. I represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. Glad to have everybody here. We are also joined by our staff, Anna Broom.
Hi, I'm Anna Broom. I'm one of the legislative analysts for this committee, and I work in the Nonpartisan Office of Policy and Legal Analysis.
and Erin Dooling.
Good morning. My name is Erin Dooling. I also work with the Office of Policy and Legal Analysis and staff this committee.
And Carrie Withy is our clerk.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
And Luke Lazur, if you're there, you can introduce yourself.
Good morning. I'm Luke Lazur. I am from the Nonpartisan Office of Fiscal and Program Review.
So, Dr. Shaw, welcome. Thank you for being here. We obviously have lots of questions. The ones that have been submitted to you. These represent our concerns as expressed from the constituents. So if you can give us some answers to the key ones, we'll just work down the list at your discretion and save questions until later on in the hour.
Very good. Senator, before I dive in, just a procedural question. As I understand it, I'll try to do about 30 minutes or so based on the written questions, and then leaving the balance of the time for open forum. Is that about right, sir?
Yes, that'd be great. Presuming that the 30 minutes gives you enough time to get to the key questions that have been asked, and we can flex on that a little bit.
Okay, very good. Well, thank you, Mr. Chairman, and members of the HHS committee. I appreciate, as always, the opportunity to speak with you today, and I will try to be as thorough but simultaneously expeditious as I can in answering all of the questions that we have. Let me start at the top with a couple of key updates to set the table on where we are with COVID, as well as one non-COVID matter. Let's start with just an early look at the case numbers that I'll be talking about a little bit later today. We've added 136 new COVID-19 cases since yesterday, bringing our total to 45,277. 1,549 people have been in the hospital, and 705 people have died with COVID. Thankfully, that number has not gone up since yesterday. On the vaccination front, we've now administered about 375,596 total vaccines. Yesterday alone was a big day in which 11,165 doses were administered. That also means about 130,900 people in Maine have been fully vaccinated. So that's where we start with respect to COVID. There is one important non-COVID matter, which is that Senator Moore, yes, we have taken multiple trips to the wildlife park in Gray, probably almost a dozen now, to hang out with, among the numerous creatures there, the moose. So we have gotten our fill of moose. So thank you for remembering that. That was a big feature. So with that, I will dive into some of the questions. And again, I'll try to balance moving through them, but also trying to answer them as directly as possible. If I've not done so, please feel free to tell me so, and I can elaborate a bit more. But moving down the list, just as the categories are, some of the basics around the vaccine. And the first question on the list on the document comes from Representative Lemlin, which focuses on the vaccine generally. Why do we use the term vaccine? When, as the representative writes, when by CDC definition, these are not even close to a vaccine? Is the term being used as a selling feature since it is not factual? The question goes on, these so-called vaccines do not actually impart immunity or inhibit transmissibility of the disease, so on and so forth. Unlike real vaccines, which use an antigen, these use a synthetic RNA fragment encapsulated in a nanolipid. So I think I think the bottom line here is not so much the term that is applied to these, although these products, whether they are the products by Pfizer, Moderna, or the product that was just authorized, manufactured by J&J, most certainly do meet the technical as well as the scientific definitions of a vaccine, which is to say a substance that is administered to a person that induces an immune response that is both short-term as well as durable, intended for the prevention of disease. So they certainly meet that definition. But leaving definitions aside, I think the question here is whether they work. And that is, there is little doubt that the three vaccines that we have before us are remarkably safe as well as remarkably effective at reducing whether it is instances of mild disease, serious disease, or the things that we really care about on a patient-by-patient basis, which is the reduction in hospitalization as well as death. I want to focus on those last two in particular, because there have been some concerns about the latest vaccine by J&J. On this score, we should all have great confidence, as I do, in all three vaccine products, because all three are simply spectacular at reducing what we really care about when it comes to the reasons we administer vaccines, which is keeping people out of the hospital and keeping them alive. And on that front, all three vaccines reduce the likelihood of being hospitalized, severely hospitalized with COVID, i.e. needing a ventilator, or dying from COVID. They reduce that likelihood by 100%. They do so through different mechanisms, but they all achieve the same endpoint, which is a 100% reduction in death related to COVID-19, no matter where they were tested and at what time of the pandemic. That is a stunning success. Here we are 51 weeks after our first case in Maine, and to have three vaccines that can reduce the likelihood of death and severe disease is simply a scientific achievement like no other. So I'm very, very confident in all three of these vaccines, and I'm hopeful that there will be more to come. Senator Baldacci asks, if I may, Senator, condense the question a bit. I understand the thrust of it to be, can and how can we do better at collecting particularized data around individuals who are disabled and tracking their rates of vaccine and vaccination? Is that a fair summation of the question, Senator?
Yes, it is. Thank you, Dr. Shah.
And your Senator, I completely concur with you. There are, in addition to those who are disabled, there are other categories where we are not capturing all the data around who is being vaccinated and by implication, who is not being vaccinated. Individuals suffering from a disability or living with a disability, I should say, are among those groups. There are others as well. What we have done as the first go, whether it was around testing, now with vaccinations, is to largely follow the rubric put forth by the US CDC around which data are gathered. And those data include age, race, ethnicity, gender, location, things of that nature. But we shouldn't stop there. We are talking about how we can expand the reach of the data that we are capturing. Certainly disability status is one of those. We're not there yet, to be candid with you, but I concede that it's important. There's no question about that. It's something that we need to work harder on. Next question that Senator Baldacci raises is, would Maine CDC consider linking vaccine and Medicaid databases to address the larger universe of vaccine equity issues? That's a possibility. I will say though, Senator, IMPACT, which is the vaccine registry we use, unto itself is quite robust. Now, it doesn't have some of the data that would come by conjoining with Medicaid. There's no question about that. But on its own, IMPACT affords us a lot of data, again, on where folks are getting vaccinated or where they're not. If we can do so, if we can enhance the clarity of the picture that we see by joining it with Medicaid databases, that's something we will look into. I can't promise that we will, but I can promise you that we will certainly look into it. There's always a challenge in mashing up two data sets from different systems and making sure we do so in a way that generates answers to questions. So I can assure you we will look at it, but I can't make any assurances that it will ultimately answer the questions that we've got around access, pockets of resistance, things of that nature.
Thank you very much, Doctor.
Absolutely. The next category of questions is around vaccine eligibility. Representative Zager asks, how did the CDC weigh the vulnerabilities of age cohorts against the vulnerabilities of those with the most severe comorbidities? For example, cystic fibrosis, cancer, etc. Representative Zager recognizes that the process of sorting into severity groups would be an operational drag on efficient vaccine deployment. And he notes in his question, he's looking for more insights into the research findings on which this determination was made. As we're only 15 months into the pandemic, what's the level of the hierarchy of evidence? Was it a meta-analysis, et cetera? Representative Zager, thank you for that question. I know exactly where you're coming from. And so let me say a few things. The first is all of the studies on which we relied, or on which I relied, were independent population level studies. I am happy to send them to you. They were all peer reviewed. So these were not preprints. These weren't things I found on medRxiv that may or may not pass the test of peer review. They had all been published and peer reviewed. They were all independent population level analyses, ranging in panel sizes from 20,000 all the way up to one with 64,000 people in them. And they used a mixture of univariate and multivariate analysis. Now, as your question notes, we are still learning things around the risk factors and predictive factors for diseases like hypertension, diabetes, and atherosclerosis, which have been with us for, and described in the literature for 100 to 200 years. So on some level, this is a first cut at the data. But what I was struck by was the uniformity in the findings, which is to say, the risk factors that stood out to me, which accorded with what we found in Maine, were age, as well as a few medical conditions that seem to be have an outsized predictive value, whether it was a hazard ratio or a likelihood ratio. Now, as I think your question indicates, but I want to be clear for everybody, we are not suggesting that these are the only factors that matter. We're not suggesting that age is the sole determinant of whether somebody will die or suffer from COVID. What we are suggesting, however, is that in a project that is explicitly about mass vaccination, vaccinating the greatest number of people as quickly as possible, if there were one question that we had to zero in on to help us sort through the process by which folks could get vaccinated, the composition of the line, that single question is age. Does that suggest that there are no 58-year-olds who are more at risk than a 61-year-old? No, not at all. There are undoubtedly those individuals, but as we are thinking about 1.3 million people who have to eventually be offered a vaccine, age is the one that, as Representative Zager's question notes, is not only strongly predictive, recognizing that 98% of deaths in Maine have been among those 50 and over. It's also one that, at the point of administration, is one that can be adjudicated quickly. I've spoken with the operators of some of the largest vaccination sites in Maine, including the one that Senator Baldacci referenced in Bangor. And the message was clear. Whatever we can do to set clear, easily verifiable criteria will speed up their flow to get them to thousands of people per day. It just so happens that in addition to being one that is easily administrable, this one also happens to capture a large number of the predictive or indicative value that we want. Representative Zager, I'll be happy to send you the papers. One final note, not fashioning myself as a dyed-in-the-wool biostatistician, I also wanted to make sure that I was reading these analyses properly. And so I sent all the papers, not with my analysis, I didn't want to prejudge them, but I sent all of the papers on which I relied to two colleagues of mine. One's a biostatistician and a computational physicist at Harvard Medical School, the other at Stanford. And I just sent them the papers to ask them for their collective reading of them, not prejudging the conclusions whatsoever. But I wanted their summation of this body of research, and both of them completely independently came back and said, age is really what's going on here. It's a proxy for so many other things, but it is a proxy that also happens to be easily verifiable. Both of those are colleagues of mine from medical school, so that's how I knew to reach them. That was a long answer, but it's an important topic, and so I wanted to dive into it a little bit more deeply. Senator Moore asks, why were the goalposts with regard to vaccination, particularly with regard to teachers, changed? If we want to get the economy going again, we need teachers because our labor force relies on the child care they provide, if nothing else. By moving the requirements for vaccines to age only, we're effectively saying most teachers won't be vaccinated until this summer. Well, Senator Moore, a few notes there. The first is, one of the reasons in which we changed our approach to teachers was to align it with President Biden's directive. The president on Tuesday afternoon announced that he was directing states as well as those who are vaccinating to prioritize, or rather make eligible teachers for vaccination process, as well as childcare providers. We don't disagree, and that's why we are taking steps now to ensure that teachers are able, per the president's directive, to at least be able to access their first dose this month. But your question still leaves open the other question, which is why not do so originally? Well, there again, in a system where we wanted to make sure we were vaccinating as many people as possible, as quickly as possible, age was one of the strong predictors that we could use to move through that. So, but we certainly understand where President Biden, as well as so many teachers, are coming from. And we have no objections. And so we are adapting our system, as we've adapted so many times, to make sure that we too can offer vaccinations for teachers, educators, school staff, and childcare providers. Senator Moore's next question is in keeping with the prior question. And so I'm going to move to the next category, which is around access to vaccines. Representative Zager asks, what consideration was given to an educator's vaccine blitz followed by the age-based approach? Well, it's not so much that it's sequential, Representative, it's that we are doing them both at the same time. So we are simultaneously working to vaccinate educators, again, in keeping with President Biden's directive to make all teachers and childcare professionals able to at least access their first dose this month, while simultaneously offering vaccine to those 60 and over. It is important to note that those numbers in Maine break down in the following fashion. Pursuant to the president's directive, there are approximately 60,000 or so individuals in Maine who are either educators or school staff, as well as childcare professionals. About 10,000 of those individuals were 60 and over, at least as to the educators. So the Biden administration's directive introduces approximately, very approximately, 50,000 new individuals who are eligible for vaccination in the month of March, at least their first dose. This is in addition to the 200,000+ individuals who are 60 and over, who are also newly eligible in the month of March. I just want to note that we, that, and our numbers bear this out, the supply of vaccine coming into the state will be uneven for the next several months. I'm sorry, several weeks, correction, several weeks, not months. That is to say, the J&J vaccine, for example, which we received 11,500 doses of this current week, we will be getting none of it next week. So for the foreseeable week or two, we have more folks to vaccinate and less vaccine to vaccinate them with. So that's going to be a challenge. That is definitely going to be a challenge. Representative Craven asks, when will primary care doctors get the vaccine so that folks like families who have severe underlying conditions, such as a child with autoimmune disease, can get vaccinated safely? Representative Craven, that is a function of the supply of vaccine. Right now, in an era of mass vaccination, where the imperative from the US CDC is to vaccinate as many people as possible, as quickly as possible, we are focusing our vaccine allocation on the large, high throughput sites. When the vaccine supply becomes more robust, and we believe that may happen, according to the US CDC director, in mid-April or so, perhaps late April. Let's hope it's sooner. But when the vaccine supply becomes more robust, we look forward to working with physicians, be they independent physicians or other outpatient providers, to equip them with the vaccine. Now, I don't know that that will mean that, say, a child with autoimmune disease will be able to be vaccinated. The vaccine right now is not authorized for anyone under the age of 16 or 18 for two of the other vaccines. So I don't know, I can't promise that a child with autoimmune disease will be vaccinated anytime soon. That is a function of when the manufacturers complete the studies, submit them to FDA, and FDA amends their emergency use authorization for that purpose. But right now, the vaccine is not authorized for children. Representative Connor asks that we provide our committee, the committee, with more information on the decision to take away vaccines from hospitals if they don't follow the guidelines. Representative Connor notes, this seems contrary to the overall goal of vaccinating Mainers with velocity. Well, Representative, one note right at the top, we've not taken vaccine away from any hospital at this time for not following the guidelines. We have shifted vaccine around extensively. Indeed, the list that we publish every Thursday of where vaccine is being allocated is merely the first stop, not the last stop for most of those doses. Throughout the week, we are moving doses around the state to load balance across the state. But that should not be seen as taking vaccine away from any provider or hospital. The simple fact is, if they can't use it within the next time period, and we've got a place that can because they have a lot of folks scheduled, we will move it. We've been clear about that from day one, and I have not been shy about moving it, whether it's from a hospital, a clinic, or a pharmacy. But your question suggests something a little bit different, which is on the enforcement front. There too, although we have not done so, if we found any provider, hospital, clinic, pharmacy, what have you, any provider that was systematically disregarding the governor's prioritizations or the Maine CDC's rules around vaccine administration, equity, eligibility, or priority, I won't hesitate to move the vaccine away from them. We, of course, always balance that with the need for vaccinators in the community. So I don't want to suggest it's a single issue analysis. There is always a balance. But if there were a situation that were systematic, egregious, and evidence of continual flouting of our rules, I won't hesitate to move the vaccine away from them. Balancing it with the good that they're providing in the community, always trying to be reasonable on that. Representative Connor also asks, when will pharmacies, particularly, for example, Shaw's and Lewiston, begin administering the COVID vaccine? And when might we see an expansion beyond the 3 that are currently active? That too relies entirely on supply. But we also look not just at the supply, we also look at the geographic distribution of the pharmacies. The 3 that we've picked and worked with thus far, Walmart initially, then Walgreens, and most recently Hannaford, have a number of features to them. For example, they can report electronically to us, but they can also do a fair amount of throughput. Those are 2 critical elements. But one that I think is important, and I'm not suggesting that Shaw's does not meet the bill here, to be clear, but I wanted to share the approach that we take for any pharmacy evaluation. It's what's the distribution of the stores across Maine? Another pharmacy that is common in Maine does not have a great geographic distribution across the state. Indeed, for the pharmacy that I'm thinking of, there are no stores south of Bangor. That doesn't work. So we have looked not just to chains and retailers that have the ability to report electronically as well as conduct a high throughput, but also those that have a good geographic reach. As we get more supply, I envision turning on or activating further retail pharmacies, but at this time, the supply is just not there. And then what in the final question in the access category, what is the status of the rollout of the vaccine for independent senior housing locations? We've been making great progress on that front. A few weeks ago, we sent out a questionnaire, a brief survey to the operators of independent housing organizations and entities across the state to understand how many people they had, what the average age composition was, and the degree of risk within that facility. How much congregation was there within the facility? Some facilities have communal meals, some don't. And we put all of that together to try to then parcel those out to 3 groups: EMS clinicians, independent pharmacists, and public health nurses. The uptake was robust. Indeed, the operator of an EMS agency said, gosh, like as soon as you posted that, all the independent pharmacies had snapped them up. So we then went back and expanded and posted more. So we envision being able to work through that process of offering vaccine on site in independent senior housing communities and we're moving our way through. I don't know when we'll be wrapped up with it, but we are making great progress on it. This is in an effort to bring vaccine to individuals, recognizing that not all individuals can find their way to a large-scale vaccine site. So our plan all along, even though I have talked favorably about large-scale vaccination sites, our plan all along has been to recognize that it is not within everyone's purview to make it to one of those sites, particularly those who live in an independent living or in a senior living facility. Driving may not be easy. They may not have a bus. Maybe we don't want to put people in a bus. So we've always planned to simultaneously make vaccine available to those who can come to it, but also bring vaccine to those who can't make that journey. The next category of questions is around reopening. And I'm going to just scan these to see if there's a few that I can consolidate in the interest of time. But the first question on the list with respect to reopening is, why are we being asked to still use masks when 2 masks provide approximately 84% at best guess possible protection, and 1 provides only 38% according to the US CDC? This seems like a huge convenience for such a small amount of protection, if the CDC's guess, which is not scientific, is even correct. This question comes from Representative Lemelin. Representative, I respectfully disagree with the premise of the question, which is that the masks are ineffective. Based on a recent review of the studies that were published, both the US CDC as well as the Journal of the American Medical Association found that mask wearing is resoundingly effective. Even at the rates that you cite, which those aren't the numbers that I've seen, but let's even assume for a second that the numbers that you put into your question are accurate. 84% is resounding. An 84% reduction from something as simple as putting a mask on, that gets you into vaccine territory. So that alone should be something that we should prize. And for my lights, given that we're in a pandemic that's claimed the lives of 700 folks, something as simple as donning a mask that reduces the likelihood of transmission by such a staggering amount, that's a win. Now, in terms of what the future looks like in terms of mask wearing, that's going to be a question around vaccination rates. And I don't have a sense of what that will look like now, but suffice it to say that masks have been remarkably effective at reducing the rates of COVID transmission as well as acquisition. That is to say, the masks not only protect folks around somebody with COVID, they also protect the wearer from actually getting COVID. Senator Claxton asks around limitations on indoor gatherings and how those are established. And can we increase the number who attend religious gatherings? And can we establish guidelines that would allow a single person or student to attend an indoor sporting event, such as a basketball game? That could mean 30 parents in a gym with seating on the side. So let's talk generally about how we think about gathering limits. Some of it is from data sets that are collected and published. Many of those are published by the US CDC themselves in their journal, the Morbidity and Mortality Weekly Report. And they've been at the forefront of amassing the evidence around the efficacy of things of gathering limits and what the various cut points are. So those are a lot of the data that I look at personally to help me understand where gathering limits are effective in light of the other variables that we're talking about at the same time, such as masking and physical distancing. So we take those data. We also benchmark our progress against other states. Other states have, throughout the pandemic, been laboratories of democracy, with some eschewing gathering limits and some following Maine's trend of being direct about them. And I think as a result of that, you've seen differences across the states. When you take a look at states that were hesitant to impose gathering limits or mask requirements, South Dakota, Idaho, Wyoming, and North Dakota come to mind, you see significantly higher rates of cases adjusted for population, as well as significantly higher rates of death, also adjusted for population. I should also note that those are rural states in the same fashion as is Maine. But when you look at states that have championed those public health measures, masking, gathering limits, et cetera, Maine, Vermont, and others, you see commensurately lower rates. Now, in terms of the increases, with respect to religious gatherings, Senator, I should note at the top, Governor Mills did just harmonized the approach to religious gatherings to make it more akin to other types of events that effectively increased the amount of people who could be attending any religious gathering. That was done a couple of weeks ago. But I hear your question to be whether it can be increased more. There's nothing unique here about religious gatherings, so I want to talk about gatherings in general, not just those that are in a house of worship. We're taking a look at that. As case rates have fallen, as vaccination rates go up, we are looking at the extent to which it may be safe to increase gathering limits writ large, not just for houses of worship. I don't have any announcements to make on that regard today, but I do know that we are looking at that very, very intensely because things are changing from an epidemiological perspective. The same applies, Senator, with respect to indoor sporting events. There, it's less about the event itself and more about the gatherings that might be occurring in the stands. But there too, as the epidemiological picture changes because of vaccinations in part, we're taking a look at what we can do to keep pace with that. Senator Moore asks, once teachers are vaccinated, is there any valid reason why students should not be able to attend in-person classes? If not, what are the reasons why? Well, what we've heard from educators is that in addition to having vaccinations for teachers, which we talked about at the top of the session, there are other concerns that they've raised, namely around physical distancing. So we are taking a look at that as well. The data around physical distancing in Maine have shown that 3 feet of distance have been able to make classrooms a safe environment without generating transmission events. The question is, but we know that even at 3 feet, many schools still find it difficult to have students in the classroom and thus have been moving to a hybrid learning. The question is whether there can be adjustments to the 3 feet. Right now, I don't have any data to share to suggest that the 3 feet margin can be lessened, but I did I was part of a large conversation of many folks with the US CDC director on Tuesday, and Dr. Walensky noted that there are studies underway right now in Europe to assess whether there can be other changes to that distancing requirement. Senator Moore also asks if the career centers are going to open full time since those who are unemployed or underemployed are seeking to improve their work and personal life. Senator Moore, I don't have a direct answer for you on that today, but we will check with our colleagues over at the Department of Labor and others, and Molly and I will get back to you on the status of the career centers. And then a final question from Senator Moore, getting lots of questions on when things are going to start reopening. Senator, there too, yep, okay, thank you. And then we're working our way through final questions. When a person has been fully vaccinated, can they get together with similarly vaccinated friends and family for a meal or for some social gathering? The answer is yes. And let me just qualify that just a little bit for clarity. Someone who has been fully vaccinated means that they have received both doses of Pfizer or Moderna or the single dose of J&J, and 14 days have elapsed since their final dose. So that's what we mean by fully vaccinated. 2 weeks after you got one or both of your shots. And provided that everybody else they are gathering with is similarly fully vaccinated, then yes, folks should feel free to gather. They should feel free to get back together. They should feel free to hug their grandkids. The reason is that the vaccine is stunningly effective. If anything in the United States, we have been underselling the efficacy of the vaccine. The vaccine, whether it's the J&J, the Pfizer, or the Moderna products, are stunningly effective at reducing what matters, which is severe hospitalizations and deaths associated with COVID. And that's why, don't just take it from me, these are actually words directly from Dr. Fauci's mouth after his review of the data. Folks who fall into that fully vaccinated category should feel free to gather with others who are themselves fully vaccinated and resume those normal rhythms of social life. And then finally, last question in this section around travel rules. There too, we are looking at how we can adjust and update our travel rules in light of the remarkable success of the vaccine. And then, okay, last question before I turn it back over to the chairman. To what extent have certain drug therapies been able to reduce hospitalizations for COVID? The answer is to a great extent, a large extent. The monoclonal antibodies that were introduced and granted emergency use authorization in the fall are quite effective at reducing hospitalizations, provided they are administered early in the course of someone's COVID-19 illness. That is to say, before they become ill, rather than, and not waiting until they become too ill. And in that regard, they have been quite effective, and we have worked with and urged providers to find and use those therapies. We've got them, they just need to reach out to us and we can dispatch them. So with that, Senator and Chairman, I will send things back over to you.
Thank you, Dr. Shaw. That was a sprint through a whole bunch of questions. I appreciate your accumulating those and getting to answers. And let's go around quickly. I think with the time left, why don't we just ask the questions, and then we'll see if there's time for answers after we have everybody have a chance to ask any additional questions. So I'm just going to go around the horseshoe and see if, for instance, Representative Connor has a question you'd like to put on a list that may or may not get answered today.
Thank you, Mr. Chair. If I may, I reserve to let the cogs turn and come up with a question.
All right. Representative Craven had her hand up early.
Thank you, Mr. Chair. Thank you, Dr. Shaw, for all you do. I feel like, you know, you're my very personal friend. That's because I see you all the time. So I had to step away for a few minutes, so maybe I missed this, but I've had several inquiries from families who feel like they're literally imprisoned in their house because their child has either cystic fibrosis, that's the biggest one, or other autoimmune kinds of diseases, and wonder when their private docs might have access to the vaccination so that they can feel safe going to their doctor to get the vaccination, as opposed to going to an open vac site that worried them about bringing the disease home to their child.
He did address that, well, I guess while you were out of the room.
I'm
Go ahead,
so
Dr. Shaw.
Certainly, Representative Craven, I absolutely hear that concern. Parents are worried about any trip that they might make outside, whether it's to the grocery store or to a large-scale vaccination site, potentially bringing something back home with them that could infect their children, particularly in the case of children who have chronic diseases like CF. I absolutely hear that concern. Let me first answer your question directly, which is the rate or the time at which we may be able to provide vaccine to independent clinicians. It depends on what the supply is. And that may be, based on what we're told, it may be several weeks before the supply starts to ease. Indeed, next week in Maine, we're getting less vaccine than we did when we got this week. That being said, Representative, I should say I've visited now a number of these large-scale vaccination sites, and I would have no qualms about asking a relative who either had a child who is immunocompromised or themselves who may have chronic medical conditions. I would have no qualms about being vaccinated there. I'm going to make a bold statement that I may rue, but there are some reasons to believe that those large-scale sites may be even safer than a small office. The ones that I visited are spacious. They have robust ventilation. There are clearly delineated path marks where there are 6 or 8 feet among people. You don't get in unless you've got at least one mask on. And the ones that I visited, even though I already had a mask on, they made me put another one on. They are fast. They're in and out in 18 to 20 minutes with the observation period, which reduces the likelihood. So there is much to be said, even for those parents who are caring for ill children. There is much to recommend for those large vaccination sites. I would not shy away from one. I have an uncle in Houston who has got a lot of chronic medical conditions, and he asked me how he should be vaccinated, and I told him not to shy away from the large-scale site that had been put up in a tent in Houston by Methodist Hospital, because he would be in and out in 15 minutes rather than having to wait in a crowded medical office.
That's the experience I had. I've had both my shots. Thank you.
Thank you, Representative.
Senator Moore?
Thank you. My question, I guess, relates more to like the Walgreens and the Walmarts, and the dosages that they are getting. Those are separate from the state's ones. Okay. Now, but are they still required to follow our age requirements? Okay.
100%.
Okay, because there was a couple of Walmarts. I heard that they were opening it up to their staff if they had any left over at the end of the day, and so
it is true. They are allowed at the end of the day, if they happen to have a dose or two, they are allowed per a document that we put out publicly, that's on our website. They are allowed to offer it to whomever at the end of the day, but it's very clear in that document they should try to abide the age categories first. Okay. And if they're not able to do so, find folks who are otherwise eligible, and then and only then, after the end of the day and the doses are about to expire, provided to any willing participant. But we are very clear in that full use policy that, or the optimum use, that they should first look beyond the scheduled folks to those who are already in the age category.
Great. Thank you. That clarifies a lot. Thanks.
Representative Meyer.
Thank you, Mr. Chair, and thank you, Dr. Shaw, for being here today. Given the change in eligibility to an age-based criteria, I do want to advocate once again for a group that was not included in phase 1A before we made this change within the healthcare worker category, and that is home care workers, known by a variety of different titles: personal support specialists, direct support specialists, home care workers who come in direct, often intimate contact with seniors and disabled folks at home. And I just want to once again bring to your attention that these folks are at high risk. And they have not been included to date. And at this point, based on the new criteria, may not see their place in line come up for some time.
Representative Perry.
Thank you. Actually, what I'm thinking about is when the possibility of a pediatric dose may occur.
It may be some time. I was briefed on this at an advisory committee, CDC advisory committee meeting. Pediatric doses are not, if even authorized, may not be until the summer, perhaps late summer, maybe even early fall.
Representative Stover.
Yes, thank you. Dr. Shaw, one of the questions I have is, now that school districts and school personnel and teachers are included, is it possible for those doses to go directly to the school to be administered by school-based health centers or school nurses, just creating more efficacy for teachers and school personnel than having them travel around the state where they can get an appointment?
Representative Madigan.
Thank you. Thank you for being here, Dr. Shaw. Similar to Representative Meyer, I'd like to take this opportunity to advocate for a group of workers, and that would be child protective workers. They often go into the homes where grandparents have custody and perhaps maybe the sole caregiver for at-risk children. They're going into homes under potentially dangerous circumstances with folks who may not be following any sort of social distancing guidelines or health guidelines. And they're folks we really need to protect children at this point. What I've heard in talking to a number of them is their concern about they don't want to ever be the person who brings in COVID to a home where the grandparent may be the sole relative caring for a child. And if they became ill or unfortunately died, then the child would be in foster care, not even with family anymore. So just want to put that out there, that it seems to me these frontline workers are pretty important.
Senator Baldacci.
Thank you, Mr. Chair. And Dr. Shaw, I do want to reiterate how important your public health leadership has been. I'm certain that it has saved hundreds, if not thousands, of lives. So I want to just publicly thank you for your service. The Bangor facility, we're very fortunate in Bangor to have the Cross Insurance Center, which the city just built like about 5 or 6 years ago at a cost of $65 million. So I would assure everybody it is clean and safe and spacious. And the city of Bangor is putting in its own money to make it, as well as the hospitals, to make sure it's safe and effective for people. My question, Dr. Shaw, I received a question from a grandmother in Bangor whose daughter was diagnosed with Hodgkin's lymphoma and is awaiting a stem cell transplant at Dana-Farber. She has called me several times, and obviously I don't have the answers, but I don't mean to put you on the spot, but I need to ask you, what do I tell this grandmother about trying to have her 19-year-old daughter vaccinated so she can also get a stem cell transplant?
And a last question from Representative Zager, and then we'll get some answers.
Thank you, Mr. Chair. Number one, I want to just acknowledge, as has been mentioned, the great fortune that we have, both that the things that are within reach for prevention are super effective, whether it be the masking or distancing or the vaccines. Also to acknowledge the tremendous leadership, the role that leadership plays in this. And I think that the state-by-state comparisons are bearing that out. So I appreciate the work, Dr. Shaw, that you and others are doing in that regard. I echo Representative Meyer's advocacy for home health care workers and similar folks in our health system to be considered 1A healthcare workers. There are lots of vulnerable constituents and people throughout the state whose lives and livelihoods and dignity really depend on these folks, and this committee has heard a lot of things regarding budget and workforce in the home health care and the direct support workers. So I think this is something that we could do that would matter for a lot of people. Thank you for offering to send the studies that you're basing your decisions on. I would love to see the state-by-state studies that you mentioned, South Dakota and others as well. And thank you for being so evidence-based in your approach. And lastly, you mentioned the monoclonal antibody treatment that are effective, and that providers ought to contact the CDC to get doses, you're saying. I would like to know, please, if you're satisfied with the mechanism, the advertising, that is the process, and that people are using that, that providers are using that mechanism to obtain the monoclonal antibodies to their maximum extent. So three comments and a question.
Max packing. I have two questions, but I'll just get those to Molly Bogart, and we'll leave the rest of the time for Dr. Shaw to selectively answer any of those myriad questions.
Very good. Thank you, Mr. Chairman. I will sort of go in reverse order. To start with Representative Zager. So with respect to the monoclonal antibodies, it's interesting. I try to spend weekends catching up with experts and thought leaders to make sure that if there's a paper I missed, I was still aware of the latest. And I spent some time on one of the weekend days, I can't remember which, on the phone with a former colleague of mine who's a infectious disease expert at UCSF, just to get caught up. And I asked him, his name's doesn't matter. I asked him, what's the latest on the monoclonal antibodies? Am I missing something? And what's the latest? And he said they are remarkably effective. And if anything, they're being underutilized by providers across the country. Even at his institution at UCSF and Stanford, there's just a reluctance to use them. And he's been trying to change that. The mechanism is actually one that has changed recently. So we at the CDC are helpful. We can help locate them. But initially, the way that they were delivered by ASPR, the Assistant Secretary of Preparedness and Response, was in a depot model with the state health department, similar to remdesivir. But that changed actually in the fall. And now they are being distributed and ordered by institutions themselves, as the institution would order any other drug, whether it was a vaccine or any other injectable. And so the challenge, so we can help locate them, but so can institutions, because they can order them directly from Cardinal or McKesson or directly from the manufacturer. And there too, we based on the data that I've been briefed on, they are quite effective, provided they're administered early on. They are a challenge to administer because they have to be in an infusion center or in an ED, which itself poses challenges. But when caught, when used, they seem to show great efficacy at keeping folks out of the hospital. Let me kind of reverse order here. The questions about different categories of folks eligible for vaccination, be they home care workers or child protective workers. Let me start with one level set. home health workers, i.e. licensed nurses and others who are tasked with going into the homes, they have always been part of phase 1A. Indeed, in the very first allocations that we made, the first week of vaccination on December 14th, doses were administered, given to home health agencies to vaccinate their home health staff. But I know the question is to cast a broader ambit beyond that, which is to say to other direct service providers, child protective workers who are going into the home. That's something that's under consideration. Again, it's supply dependent, but I also think it's important to note that those who were noted as being potentially exposed, grandparents, the elderly, are in the main currently eligible. So I think that underscores the need for folks who are eligible for vaccine to make sure they are getting vaccinated, because that reduces the likelihood that they may get exposed or become ill if they happen to have an interaction with a home worker, or home care worker, a direct service provider, or child protective services. But as more vaccine supply becomes available, then we too can expand the ambit of those who are eligible. I can't promise that that will be home care workers, direct services providers, CPS staff. I can't make that promise. That's ultimately the governor's determination. But right now, supply is the constraint. Also, questions around teachers, particularly our ability to utilize school-based health centers. Right now, all options are on the table. But again, the president's directive was to at least offer or make available the first dose to all teachers this month. So we do need to take parallel approaches. School-based health centers are already quite taxed with managing cases of COVID, dealing with other childhood ailments that may crop up in the school. Adding on top of that, the imperative to vaccinate teachers, staff, bus drivers, cafeteria workers, and other school staff, that may be a challenge. So we're going to need to help them out. We're going to need to open up other channels of vaccination to make sure all of those groups, which again number about 50,000 in Maine, to make sure all of those groups can get their first shot. School-based health centers may be part of that, but as you can see by the numbers, 50,000 people, school-based health centers may be overtaxed in that. And then finally, questions around, just make sure I'm picking everything up. Final questions around those who are in very unique situations. Senator Baldacci mentioned one, and Representative Craven did as well, with parents as well as younger people who are suffering from various and significant ailments right now, be it Hodgkin's lymphoma, cystic fibrosis. It's an incredible, incredible challenge. I don't mean to discount that 1 second, and that's why I wanted to answer it directly. We're still in a situation where supply is the #1 constraint on our ability to vaccinate as many people as quickly as possible. Again, I've mentioned it and it bears repeating. Next week in Maine, we're getting fewer vaccines than we got this week, on the order of 10,000 doses fewer. That means that there are very difficult challenges. And although there are certain individuals who may be uniquely at risk, so for example, Senator Baldacci, the family that you mentioned, one of the things that we have urged and been successful at doing is urging them, to the extent they are, say, going to Dana-Farber, to be vaccinated at the site of care. That's an option that we've seen bear some degree of success. But as we get more vaccine, we too can expand who is vaccinated. I say that recognizing the challenge that it is. I'm not going to shy away from that. I don't want to dodge your question. I know it's tough. Every decision that we make around who is eligible, by implication, may mean that someone is not eligible. That is unfortunately the nature of the challenge that we are in. I don't want to shy away from that. It's incredibly difficult. But as we get more vaccine, we hopefully will not have to make those difficult choices.
That brings us to 10 o'clock, and I understand you have to chair a meeting.
I unfortunately do, but Mr. Chairman and members of the committee, I appreciate your time today. I appreciate you all with the thoughtful question, asking thoughtful questions and giving me the time and the space to answer them completely.
And other questions as they come up can go to Ms. Bogart and be worked on by the department. So thank you again for being here, and thank you for sprinting through some of those questions.
Thank you, everyone.
All right, so I would propose a 6-minute break, and we'll reconvene here at 10:07. And I see Mr. Mann has joined us. So it's 10:07 and we can resume the committee work. We're now moving to a consideration of the Department of Health and Human Services budget. And for help with that, Luke Lazur joins us, as does Deputy Director Mann and Mr. Jeff Wiley. So if you want to introduce yourself, Deputy Director.
Good morning, everyone. My name is Benjamin Mann. I'm the Deputy Commissioner of Finance at the Department of Health and Human Services.
And Mr. Wiley?
Good morning. I'm Jeff Wiley. I'm the Budget Director for the Department of Health and Human Services.
So at this point, we've been joined by, where did Representative Griffin go? There she is. Representative Griffin, you weren't available this morning.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glumberg, Levant, and Cadesque.
Thank you. Okay. That's everybody. So we'll turn it over to Luke.
Great, good morning. So I'll say the same thing I did at the beginning of yesterday. If you have a number of lines you want me either to read or that you want to vote on, just jump right in. No problem at all. We'll start with today, adult mental health. We'll also be looking at developmental disabilities and intellectual disabilities, and then elder services. So adult mental health begins on page 1 of the green document at line 21. And this is in the Dorothea Dix Psychiatric Center, DDPC, which is account Z222. And this provides funding for the integrated care management system at Dorothea Dix Psychiatric Center.
Okay.
Mr. Chairman, I would move to include line 21 in the budget.
Second.
So if there's no objection, what about going to line 22? Let's include line 22 in that motion, 22 and 23.
And what about 24 and 25?
As long as we're on a roll, let's keep going.
Well, those are all the ones that deals with Dorothea Dix. So if we
I
can
understand. Yes.
move
So
those, we can move those together as a block, that would be great.
is everybody comfortable with expanding that to the whole first page through 25? That being the case, then why don't you go ahead and run the roll, Carrie?
Did you have a second on that, Senator Claxton?
Yes.
Okay, gotcha.
Thanks for covering.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
I believe she had to step away for a public hearing for a testimony.
Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes.
Great, that moves on to line 26, which is in the Riverview Psychiatric Center account Z219 and provides funding for the integrated care management system at Riverview Psychiatric Center.
And we should keep going. Yes, Senator Moore.
Yes, I was just going to make a motion that we move lines 26 through 32 into the budget.
Thank you for that. Is there a second?
Second.
Yes, there is. Carrie, you're up again.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner, Representative Javner is absent. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes.
Okay.
That moves on to line 33, which is in the Mental Health Services Community account Z198, and provides funding to continue the Crisis Center in order to meet the requirements of the consent decree to provide crisis services in Cumberland County.
Representative Meyer had some questions related to this line.
I'm sorry, where are we?
I'm sorry, we're on 33, page 3, line 33 at the top. I have a notation that you had some questions. I don't know whether they're still active or not. This is the line item for the crisis center as part of the consent decree and specific to Cumberland County.
Correct. And my notes indicate I was just looking for a little bit more clarity around that crisis center. And Ms. Bogart had sent an email earlier with some answers. I'm assuming, is there an answer to that question in what was sent, Polly?
Yes, let me pull that up. I mean, broadly, the crisis center is meant to be, or receiving, it's a term that many folks use different terms for the same thing. Receiving center, it's really a suite of services that can help fill out our crisis continuum of care and be a place for folks to receive services either self-referral or through connection with law enforcement, rather than being brought to police station, a jail, or an emergency room. But let me.
Is this mobile or brick and mortar?
Well, it's a set. There are people who are going to provide the services, and there's what's called the living room model. And so there will need to be a brick and mortar location, but it's a hub for a number of services that include mobile crisis services, certainly.
And for right now, the reference to preliminary funding means that until we get a brick and mortar, until we figure out exactly what we need to do, this is the start.
That's right. It's we don't run a crisis center right now, and we're just establishing it, so we don't know what it will cost entirely. It depends on the main care proportion of members that attend as well, which would be paid separately. So we're asking for a modest amount of money here to help fund the ongoing operations of it.
Okay, thank you. Are there any other questions related to line 33? Okay, should we go on to 34?
All right, line 34 is also in the Mental Health Services Community Z198 account, reduces funding in the Mental Health Services Community Program by recognizing contract savings and program efficiencies.
So I'd entertain a motion to move 33 and 34 into the budget if there are no other questions.
I'll make the motion.
I hear a motion and a second. Go ahead, Carrie, then.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes.
So with that, we move on to line 35. This is also in the Mental Health Services Community Account Z198. This one establishes one Public Service Executive 3 position, one Social Service Program Manager position, and 8 Intensive Case Manager positions, funded 100% general fund in the Mental Health Services Community Program to coordinate services related to individuals with forensic health needs across the state.
Should we include the next line? Okay, so let's go to 36
So
and
36,
37.
yeah, 36 and 37 are in the Mental Health Services Community Z198 and Office of Substance Abuse and Mental Health Services account Z199. This establishes one Public Service Manager 3 position funded 50% general fund in the Mental Health Services Community Program and 50% general fund in the Office of Substance Abuse and Mental Health Services Program to serve as a Deputy Director of Operations.
So I'd entertain a motion to move those 3 items into the budget.
So moved.
Second.
Second, thank you. Carrie?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes.
All right, then we're on to line 38, which is in the Mental Health Services Community Program, account Z198, and it provides an allocation to align with available resources. This is an increase to the federal block grant fund allocation.
Senator Moore?
Yes, thank you, Senator Claxton. I would like to make a motion to move lines 38 through 43 into the budget.
Thank you. A second?
Second.
And the second was heard. Okay, Carrie?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes.
Okay.
So with that, we're done the adult mental health portion of the green document. So we'll move over to the purple document, the language. And we'll start with part UU, which is line 495. And part UU, this part authorizes the Department of Health and Human Services to transfer by financial order available personal services balances in the disproportionate share Dorothea Dix Psychiatric Center program, the disproportionate share Riverview Psychiatric Center program, the Riverview Psychiatric Center program, and the Dorothea Dix Psychiatric Center program in order to provide flexibility in the payment of operational expenses.
Mr. Chairman, I would move to approve that language.
Second.
And a second. Is there any interest in going to VV? Including VV in this too, which we've discussed. So would you accept that as a friendly amendment, Senator? To add
Absolutely. Thank you, Mr.
and
Chairman.
a second. Very good.
And a second. Yeah.
All right. So Carrie will vote on UU and VV.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes.
All right, so we'll move on to developmental disabilities and intellectual disabilities. This begins on page 7 of the green document at line 117.
Senator Claxton, Representative Javner has her hand raised.
I'm sorry, Representative Javner, I wasn't looking. Yes.
You're forgiven.
Thank you.
you, Senator Weston. I appreciate it. I apologize. Before we move forward, may I register my votes for the ones that I missed?
I think that would be perfectly acceptable.
Thank
So
you.
the
So I would so note that for lines 21 through 25 and lines 26 through 32, I will be voting yes.
And you can update the voting tally, Carrie?
We keep the votes on the budget, Senator.
Oh, okay.
Carrie
Okay.
calls the roll, but because these aren't LD votes, we keep them.
Great, thank you. So there you go. Thank you. Thank you for flagging that, Senator Moore. Welcome back.
For now.
And
All
with
right.
that, so we're at line 117 on the green document. This is lines 117 and 118. This is in the Developmental Services Community Account Z208 and the Office of Main Care Services Account 0129. This provides funding to contract with a provider to implement and provide technical support for the use of a standardized developmental disability needs assessment.
Are there any questions about this? Can you just refresh my understanding of this? This is via an RFP, so this document doesn't exist, but part of the RFP might stipulate that if somebody already has one of these in place in some other state, we could use it. And this also implies we don't have a good tool now. Is that all accurate?
Yeah, it's a tool along with a process to determine the right level of supports for adults with disabilities. So you're correct that we would go out to RFP for the actual tool. There's several vendors that provide such technology. We detailed it in the Q&A that we were provided back as well this morning. I realize you haven't had a chance to review that, but do believe that it is essential to the determination to provide to determine whether an individual is receiving too much supports or too little supports, and to ensure fairness and equity across the system that we have in place today. And it's also imperative to make reforms, whether we want, there's interest in improving shared living supports, for example, and this would be instrumental in doing moving towards that, and also the lifespan waiver, which would combine the 4 waiver programs into one. So there's more flexibility for members across that. This type of assessment would aid in getting to reaching that point.
Thank you. Representative Craven?
Thank you, Mr. Chair. So I remember the last time we tried this, so it really wasn't very successful. And I wonder how you're going to determine a successful tool. You know, are you looking at outcomes from other states or something like that to ensure that we have a tool that works this time?
Yeah, I think one of the pitfalls last time was that it was explicitly geared toward cost savings measure. We are not focused in that area for this. This is more specific to making sure that there's an even-handedness in how needs are assessed, so all consumers and their families are treated fairly. So I think just the very high level objective and goal of the program is we've recalibrated it, which I think will go a long way. And we intend to work closely and with stakeholders to make sure that they are brought along on what the department's doing and making sure everyone is informed of the plan. One of the other things is that it was I think the timeline for the last proposal was in the year. It was a multi-year initiative. We would intend to do this on a quicker but more transparent pace, so that there's more certainty and folks are aware, stakeholders are aware of the intentions of and the goals of the program.
And I would also note, I know this question was brought up in the public hearing, and Office of Aging and Disability Services provided us with about a page of information that's in what I sent you this morning, which I recognize you probably haven't even had a chance to open up, but that outlines some of their lessons learned from that previous process, both the folks who were there during that process and the new folks, and some of the stakeholder engagement and work that they're going to do around this. So happy to answer additional questions, but I also hope that that's helpful in assuring you that we're taking a different tack.
Representative Meyer, you had a question?
Thank you, Mr. Chair. Just around the timing here, when does the department expect to implement the assessment that you select?
So the ODES noted that the previous project length spanned approximately 5 years, which of course caused stress and uncertainty for stakeholders. Once we begin this, we'll publish a clear timeline with milestones leading to implementation within months rather than years. And we'll be engaged with stakeholders over that time. So we're looking for a significantly shorter time span for stakeholder engagement and transition to provide some certainty to those families.
Thank you.
All right. Should we go on to line 119?
Great.
20.
Line
Yep.
Line 119 is 119 through 121. It's in the Developmental Services Community account Z208 and the Crisis Outreach Program account Z216. This transfers and reallocates 4 mental health worker 3 positions from 100% general fund in the Developmental Services Community Program to 52.4% general fund and 47.6% other special revenue funds in the Crisis Outreach Program, and adjust funding for related all other costs.
And I don't see any questions. How about 122?
Sure. 122 is in the Developmental Services Community account, Z208, and it reduces funding by recognizing one-time savings achieved by implementing new programmatic management practices for emergency transitional housing.
And I don't see any comments there. 123.
It's also in the Developmental Services Community account Z208, and it reduces funding one time in the Developmental Services Community Program due to general efficiencies.
I don't see any questions. So why don't we entertain a motion to approve lines 117 through 123?
So moved.
Second.
Moved and seconded. Carrie, you want to call the roll?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes.
All right, that moves us on to lines 124 and 125, both in the Crisis Outreach Program account Z216. And this provides funding for the proposed reclassification of 47 mental health worker 3 positions to community integration worker positions and provides funding for related state cap charges.
Okay. 126.
126 through 128 is in the Developmental Services Community Program account Z208 and the Crisis Outreach Program account Z216. This transfers and reallocates one human services caseworker position from 52.4% general fund and 47.6% other special revenue funds in the Crisis Outreach Program to 71% general fund within the Developmental Services Community Program and 15.2% general fund and 13.8% other special revenue funds within the Crisis Outreach Program and transfers funding for related all other costs.
Yes, Representative Javner.
Thank you very much, Chair. If there's no further discussion needed, I would move to line 137. There's no discussion in between those lines.
124 to 137.
Yes, please.
I'll take that as a motion. Look for a second.
Second.
I hear a second. Carrie, would you run that? Thank you, Representative Javner.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes.
So this moves us on to the first of the many program consolidation initiatives, which
Senator
were,
Excuse me, Luke, before we move on, may I
Yes,
just make a
Senator
comment? I just want to point out to members of the committee that in Molly's response to our questions this morning, there is some information about the wait list that we asked about for section 29 and section 21 folks. So I just wanted to point that out to the committee. That is some good information that we can have for reference purposes. So I just wanted to mention that. Since we have voted the lines in, I thought it would be good to note that.
Okay. Thank you. Yeah, that was mailed at 9:25. For those of you who are looking for it in your inbox. Okay, yes.
So
please, Luke.
with that, we're on to lines 138 through 143. And as I was saying, this is the first of the program consolidations. I did outline these separately on another document, but this one involves the Medicaid Services Developmental Services Program account Z210. Which is the receiving account where all the funding is going. And the accounts which are being reduced to move the funding there are the Developmental Services Waiver Main Care Program account Z211, the Developmental Services Waiver Supports account Z212, the Traumatic Brain Injury Seed account Z214, the Medicaid Waiver for Other Related Conditions account Z217, and the Medicaid Waiver for Brain Injury Residential Community Service account Z218. So in all, this increases funding in the Medicaid Services Developmental Services Program and decreases funding in those other programs to consolidate the 6 developmental services waiver programs into one program as part of the consolidation of the main care related programs from 13 to 4.
Yes, Representative Javner.
Thank you very much, Chair. Thank you, Luke. As much as I can appreciate this on an accounting level, and I would prefer to make things very, very simple, but as the oversight committee, I just cannot approve the consolidation of these lines today. So thank you.
And that brings up the conversation we've had previously about whether we lose the ability to track how we're doing in the provision of services by consolidating based on what's an accounting efficiency.
I don't want to speak for Luke, but I think his summary of the consolidation suggested that we would not lose transparency. It's not the intention nor the goal of the department. It is intended to produce modest savings based on the ease of flexibility of managing the accounts. I think it's been accrued over time. 13 general fund accounts. That is over 3 times as many of the federal accounts that we have, and that we would certainly work with OFPR and the committee and the legislature to ensure that there's appropriate and sufficient reporting into main care activities. We provide monthly reporting right now, and we would certainly continue to provide that, and so that you all have insight into the expenditures and the appropriated dollars on where they're going and the use of them on a monthly basis.
Thank you for that information. Representative, reinforcing that. Representative Craven?
Thank you, Mr. Chair. Does this shift the baseline as well?
Oh.
For example, as we're looking at it now, we know how much is allocated for each of the services. So I just wonder how that's going to look on the spreadsheet.
And so, Representative Craven, in the future, you would not have that detail because that appropriation would now all fall into, in this case, the Z210 account. So that would be the only account that would have any baseline. The amounts that are being transferred essentially are the baselines for these accounts. There's also language that we'll see later. We didn't do it here. We did it with the main care group just because most of the consolidations are in that group. But there is language as well that goes along with this that allows for any funds that end up in these accounts to also be transferred. So in the end, next year, if there was another budget and this went through, there would only be the account Z210. The place where you could still see the activity would be in the expenditures in the accounting system. And as I said, for most of these, I can still track that as a separate entity. The two accounts, the section 21 and 29 waivers, I cannot, because they currently go into one account within the accounting system. So that's the piece that would be missing is the actual appropriation of the dollars to these separate accounts. You wouldn't see that in the future.
Does that answer your question, Representative Craven?
Yes, thank you. I just needed to.
You on? Yeah, you go. All right. So we're now at line 138 through 143. There being no other questions, I'll entertain a motion.
Move it in.
And a second?
Second it.
And a second. So this motion and seconded. Carrie?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
No.
Representative Lemlin, no. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
No.
Representative Griffin, no. Representative Connor,
No.
Representative Connor, no. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
No.
Representative Javner, no. Senator Moore,
No.
Senator Moore, no. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 8 yes, 5 no.
And I certainly share the concerns that have been expressed, and maybe a way to address that a little bit would be to have Luke, once this transition has been in place and we've had a month or two of expenditures, come back and crosswalk the system we have in place now with what the new system looks like and how we can better understand where the dollars are going for one of these major consolidations.
And I can certainly do that at any time.
Okay, so this consolidation would be in place as of,
Well, it would become effective with the budget. So I imagine that it would really take some of the early part of the next state fiscal year for all of the funding to end up in the right place, because there are initiatives in this budget that put funding in the accounts that are essentially being eliminated. I think I spoke about this briefly. That it's the only way it can be done. So there will be time where that funding will also have to be moved. So to the point, it would take some time into the next state fiscal year before we would actually know what it looks like.
so is that something you could do by, say, October 1st and get to the committee, or September 1st?
I imagine I could at least have some crosswalk by then of what it looks like. I mean, I think in plain fact, I could sort of do that crosswalk now, just with the understanding of how I'm going to look at it in the accounting system versus this, but it would be easier once the transition's been made, because then the numbers would be actually what they are. So.
Okay, so if you can get that to us sometime in the fall, it's not a bill, it's not a mandate, it's a request. And if you could, and then we can put that on our agenda for January if we'd like to, when we're all sitting in the same committee room. Right.
I just know we'll be fully supportive of that and work with OFPR to make sure that you all get the information that you need.
Thank you. Okay.
So
onward.
That ends the developmental disabilities, intellectual disabilities portion. So now we'll move on to elder services, and this also includes some nursing facilities funding. It starts on page 15 with line 236. So line 236 is in the Office of Aging and Disability Services Adult Protective Services Program, account Z040. This reduces funding in the Office of Aging and Disability Services Adult Protective Services Program due to the elimination of the bond requirement for a public guardian or public conservator under Title 18C, Section 5-710. And I'll note there is language that goes along with this that is also part of the budget. That is what removes this requirement. That language is not voted on by this committee. I did discuss the language with you the last time as well, and we can bring it up again today, just so you understand the language. But that language won't be voted on by you. But there is language that removes a requirement that for furnishing a bond, which is what leads to this initiative and the $14,000 annual savings in the general fund.
Okay, do we want to keep going? Okay, so
Lines 237 and 238 are both in the medical care payments to providers MAP account 0147. It transfers funding for a revision to the department's rule chapter 101 main care benefits manual, chapter 2, section 19, home and community-based benefits for the elderly and adults with disabilities, which allows enhanced federal medical assistance percentage for the community first choice option from the general fund to the federal expenditures fund within the program.
yes, Representative Javner.
Thank you, Chair Claxton. I would make a motion to move lines 236 to 244 into the budget.
Thank you for that.
Second.
Thank you, Senator Baldacci. Been moved and seconded. Carrie?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes.
Great. So now we'll move to the NIF portion of this block, and that begins on page 25 of the green document, and it's with line 385. And 385, 386, and 387 are all in the nursing facilities account 0148. And this reduces funding by no longer allowing nursing facilities to claim reimbursement from the main care program for direct costs for bed hold days, since no direct care is actually provided.
Yes, Representative, Senator Moore, yes.
Thank you, Senator Claxton. I just would like to go on the record again, as we did in the supplemental budget. I really oppose this. I understand why we're doing this. However, these facilities still continue to have direct costs, whether the person is there or in the hospital. They still have staff. They cannot lay them off because they've got 2 or 3 people in the hospital. So I will be voting against moving this into the budget.
Representative Perry?
Thank you. I'm going to reiterate what Senator Moore has said. The concern that I have is in Washington County alone, we have lost 3 nursing homes because they can't afford to keep running. We are one of the oldest counties in the oldest state. And to lose these services is a significant decrease in the availability of treatment and care for our elderly. So I cannot vote for this.
Representative Craven?
Thank you, Mr. Chair. I'll also be voting against this measure. Thanks.
Thank you. Senator Baldacci?
I just want to concur in the comments of Senator Moore and Representatives Perry and Craven. This is an important issue. Bangor is a home of several nursing home facilities that take care of over a couple thousand people just within the city limits. So this is an important issue, and their survival and success is important to our community. Thanks.
Thank you. Are there any other questions or comments? So I'll entertain a motion. We can either do it on the yay side or the nay side. Does somebody want to make a motion?
I'd move not to include this in the proposed budget.
Is there a second for that?
Second.
I hear a lot of seconds. Okay. And Carrie, so the motion on the floor is to not move it into the budget. Carrie?
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes.
So the next lines are 388 through 390. These again are all in the nursing facility account 0148. This provides funding in the nursing facility program for a cost of living increase in fiscal year 2021-22 and a cost of living increase and rebasing in fiscal year 22-23.
Yes, Representative Javner.
I apologize, Senator Claxton. I would make a motion to move lines 388 to 391 into the budget.
Thank you. And a second?
Second.
Carrie?
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Sorry, it cut out for a moment.
Yes.
Senator
Yes.
Claxton, yes. Thank you.
That was me wiggling paper. Sorry about that. All
So
right.
now that ends the green document initiatives for that section. So the last thing for today is on the purple document. It is part XX, which is line 498 on that purple document. This part authorizes a transfer of all other balances from any account within the Department of Health and Human Services, excluding balances in the 4E Foster Care Adoption Assistance and state-funded foster care adoption assistance program for the purpose of the Information System Modernization Project in the Office of Aging and Disability Services.
Yes, Senator Moore.
I would make a motion that we move the language XX into the budget.
Second.
Moved and seconded. Carrie, we'll vote on this.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes.
Oh,
Representative Madigan. Oh,
Can
sorry.
we make sure everybody mutes who isn't voting? Thank you.
Yes.
Thank you. Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes.
And just for completeness, Luke, you mentioned KK as not a non-voting item, and we've already been over it a couple times.
Yes, and that line was voted in, and that's what that language was there for, was to help with that line.
Yep.
So that is everything for today.
Well done. So I turn to the analysts to see if there are other things on the agenda that you would like to accomplish for this morning. Don't all jump at once. All right, I'm not seeing anything. So I do want to acknowledge that being able to move through this stuff in an informed, coherent fashion requires a lot of pre-work. And I just want to acknowledge that and appreciate that. So thank you all for doing that and for doing your work so well. Again, a thank you to Luke for walking us through this. We'll meet again on Monday to finish going through the first pass, and we'll have a few pieces probably at the end of that to add. And then we'll return this afternoon at 1 for public hearing, introduction of 3 bills. We will start with Senator, somebody asked to go first.
Senator Sanborn.
Sanborn asked to go first. And then Representative Craven and I will arm wrestle about who goes second and third.
I'm
Okay.
very patient. I can wait to be number 3. I only have one
Right.
person testifying for me.
Right. Okay, so again, in addition to thanking Luke for leading us through this, appreciate Mr. Mann being here and Mr. Wiley. So thank you for being available. All right, so I will entertain a motion to adjourn until 1 o'clock. There's
So
the
moved.
motion. Thank you, Representative Connor. Any seconds?
Second.
Okay, I heard a second. All those in favor of adjourning until 1 o'clock. You don't have to call the roll, Carrie. It looks unanimous. Thank you. See you at 1.
Mr. Chair, I apologize for my abrupt departure this morning.
Everybody okay?
Yeah, I was I was following two hearings at the same time and didn't mean to broadcast the idea committee in ours before you muted me.
Just trying to help. It gets complicated. Yeah, moving from one committee room to another is easier in this scenario, but so many other things are harder.
I didn't even go over there and they passed my bill.
Very powerful, very persuasive argument you didn't make. So we were going to let Senator Sanborn go first, is my
We are.
recollection. Yeah.
It'll go 269, 38, then 450.
Okay.
So you'll be second.
Good thing I had a long lunch break to do my testimony.
There you go.
An introduction
it
of a
is
department bill.
1 o'clock and we have a quorum. Carrie, we all set? Thank you very much. Good afternoon and welcome to the afternoon session of the Joint Standing Committee on Health and Human Services. We are assembled around our virtual horseshoe and we are live streamed on the HHS channel found on the Maine State Legislature's YouTube channel, where you can find the replay of our proceedings should you miss us live. This afternoon, we will hold public hearings on the following bills in this order: LD 269, 38, and then 450. For those testifying, please ensure that the name you're using on the Zoom webinar matches the one you used when you signed up to testify. And we would ask that in order to help our clerk manage the attendee list, you exit the webinar once you finished your testimony and answered any questions from the committee and watch the rest of the hearing live on YouTube. We'll be taking testimony in the following order: sponsor, any co-sponsors, those providing testimony in favor of the bill, those opposing the bill, and then finally, any neither for nor against, but with additional information for the committee. We run a 3-minute clock on testimony and you'll receive a prompt when you have 30 seconds left asking you to bring your testimony to a conclusion. Public hearings are just that, for the public. The process of hearing their testimony certainly engenders and encourages probing questions, and the committee is asked to use the raise hand function in order to ask those bill-related questions. We'll do a quick round of introductions, beginning with Representative Zager.
Thank you, Madam Chair. My name is Sam Zager, honored to represent District 41 in Portland.
I am not seeing Representative Lemelin. Representative Stover.
Hello, thank you. My name is Holly Stover. I represent House District 89, including Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Thank you. I see Representative Lemelin.
Thank you. Yes, I'm Michael Lemlin. I apologize for not being on screen right away. I was on the phone with a lady in tears and trying to help her out. So anyway, I'm Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Senator Baldacci.
Hi, I'm Joe Baldacci. I'm state senator from District 9, which is the city of Bangor and the town of Herman. Thank you.
Representative Perry.
Good afternoon. I'm Ann Perry. I represent House District 140. That includes Indian Township, Baileyville, Bering, Calais, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Representative Javner.
Yes, good afternoon. I am Kathy Javner. I represent House District 141, which is located in Penobscot and Washington County.
Representative Griffin.
Good afternoon. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescag.
Representative Craven.
Thank you, Madam Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Good afternoon. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Senator Moore.
There, got it, finally. Good afternoon, I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
And my Senate co-chair, Senator Claxton. You're on mute, Senator.
I was trying to behave. My name is Ned Claxton, and I'm honored to represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester.
And I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is parts of South Berwick and Kittery and all of Elliott. And with that, we will move to our first public hearing.
And our staff.
Oh, I am so sorry. Our staff, Erin Dooling.
Good afternoon. My name is Erin Dooling. I'm one of the legislative analysts for this committee from the Office of Policy and Legal Analysis. We don't take positions on or advocate for any of the legislation before the committee. I do want to let you know what's in your virtual committee files for this afternoon. On each bill this afternoon has received a preliminary fiscal impact statement that you can view by going to the committee materials page and navigating to the status, the link. And LDs 38 and 269 also have related current law that might give you a broader context for the bills before you.
Thank you, Erin. I'm not seeing Ms. Broom and our clerk.
Good afternoon. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
Hopefully, I've not missed anyone. And we will, in fact, move forward with our first public hearing, which is LD 269, an act to prohibit smoking in bus shelters, presented to us by its sponsor, Senator Heather Sanborn. Senator.
Thank you, Madam Chair. Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. I'm glad to be here this afternoon. Excuse me, I'm Senator Heather Sanborn. I represent Senate District 28, which includes part of Portland and part of Westbrook. And I am here to introduce LD 269, an act to prohibit smoking in bus shelters. This past November, I was contacted by one of my constituents, a man named Stan, who is in his 80s and relies on the bus in order to be able to do errands and move about our city. He shared with me his many experiences of having to wait in rain and bitter cold outside of the bus shelter because there were individuals smoking inside of the shelter. In Portland, many of these bus shelters are small spaces that are fully enclosed on 3 sides plus a roof. You can imagine that finding the shelter at your bus stop filled with smoke on a cold, rainy day would not only be unpleasant, but would be harmful. As this committee knows, secondhand smoke is a public health danger that our statutes already provide protection against. Indeed, arguably, smoking in bus shelters is already prohibited by our current law. The current statute says that, quote, smoking is prohibited in all enclosed areas of public places. This bill would simply clarify that bus shelters are included as one of those enclosed public spaces. These shelters are there for everyone who wants cover from the wind and cold. Making this clarification is not prohibiting anyone from using the shelter and certainly not barring anyone from smoking. It merely means that someone will be required to step out of the shelter in order to smoke, rather than forcing non-smokers like Stan out into the cold. Stan couldn't join us today, but he has submitted a letter describing his experiences. I encourage you to read it as you consider this bill. Thank you for your time, and I would take any questions that you might have.
Thank you, Senator. Questions from the committee? Seeing none, we thank you very much. Up next, providing testimony in support of this bill is Hillary Schneider.
Good afternoon. Can you guys hear me?
We can.
Great. Good afternoon, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. As you know, my name is Hillary Schneider, and I'm the Government Relations Director for Maine for the American Cancer Society Cancer Action Network, which is the nonprofit, nonpartisan advocacy affiliate of the American Cancer Society. On behalf of ACS Can, I'd like to thank you for this opportunity to submit this testimony in support of LD 269. As you've heard, the bill clarifies our smoke-free public places law to ensure public bus shelters are included in the law. ACS Can advocates for comprehensive smoke-free public place and workplace laws to protect workers and the public from the harmful effects of secondhand smoke exposure and to create communities that support tobacco-free living. ACS Can supports everyone's right to breathe clean, smoke-free air. Tobacco users are not the only ones who breathe the deadly smoke. All the people around them are forced to inhale it too. Secondhand smoke causes nearly 42,000 deaths, including up to 7,300 lung cancer deaths among non-smoking adults each year in the United States. Exposure to secondhand smoke causes many of the same tobacco-related diseases as active smoking, including heart disease, stroke, and cancer. In addition, secondhand smoke increases the risk for sudden infant death syndrome, acute respiratory infections, ear problems, and more severe asthma. Multiple Surgeon General's reports have confirmed that the scientific evidence indicates there's no risk-free level of exposure to secondhand smoke. As you've heard from Senator Sanborn, bus shelters are important in helping protect those who wait for public transportation from the wind, rain, and snow. They can also provide safety and a place to sit. It's not uncommon for individuals waiting in a bus shelter to be sitting or standing in close proximity within an enclosed space with some walls and a roof. Many Mainers take public transportation to commute for work, to shop, worship, or travel for recreation, entertainment, or spend time with family or friends. Those Mainers deserve to be protected from secondhand smoke exposure while waiting in a bus shelter. Moreover, smoke-free public places help support healthy communities by helping support tobacco-free living as the social norm. For these reasons, we ask you to vote to pass on LD 269, and I'd be happy to answer any questions.
Thank you, Ms. Schneider. Questions from the committee? Seeing none. Next up is Sarah Calder.
Senator Claxton, Representative Meyer, and members of the committee. I'm Sarah Calder. I'm the Director of Government Affairs at Maine Health, and I'm here to testify in support of LD 269. Every day, Maine Health's over 23,000 employees are committed to fulfilling our vision of working together so our communities are the healthiest in America. And to that end, we've long supported strong tobacco prevention and treatment programs for our patients, employees, and our communities. And as you've heard from others, we know that tobacco use is one of the most preventable health problems facing our state and nation. In 2011, we established the Maine Center for Tobacco Independence, or CTI. In partnership with the Maine CDC, Maine Health implements the Maine Quit Link, training for healthcare providers and other professionals throughout the state, and technical assistance regarding tobacco-free policies. Additionally, in 2016, Maine Health partnered with the Maine CDC to implement and lead Domain 2, tobacco use and exposure prevention. As part of the Maine Prevention Services, the Maine Center for Tobacco Independence works with 16 community organizations to create tobacco and smoke-free environments across Maine and help Maine youth and young adults be tobacco-free. So with all that said, we strongly support public policies that limit the public's exposure to unwanted secondhand smoke, and we're not alone. According to the Behavioral Health Risk Factor Surveillance System, 9 out of every 10 Mainers agree that people should be protected from secondhand smoke. And so it's for that reason that we are supporting this bill that clarifies that bus shelters are considered public spaces. And I would be happy to answer any questions that you may have.
Questions from the committee? Seeing none. Thank you for your testimony, Ms. Calder.
Thank you.
Up next, testifying neither for nor against is Lance Boucher. Welcome.
Hi, good afternoon. I'm sorry, when I registered, I must have clicked the wrong box, but we are testifying in support of the bill. So good afternoon, Chairs Claxton and Meyer, and distinguished members of the committee. My name is Lance Bushy, and I'm the Senior Division Director for State Public Policy for the American Lung Association. The Lung Association is the nation's oldest voluntary public health organization with a mission to save lives by improving lung health and preventing lung disease. I'm pleased to join you today to offer the Lung Association support for LD 269. The Lung Association supports measures to require totally smoke-free environments to protect public health. And Maine has been a leader in strong smoke-free laws protecting workers, children, and non-smokers from secondhand smoke exposure for nearly a decade and a half. In fact, for 16 plus years, every year, the American Lung Association's State of Tobacco Control Report Card has given Maine an A grade for smoke-free environments. This bill offered by Senator Sanborn will help to clarify that bus shelters are enclosed public spaces and included in Maine smoke-free laws. Secondhand smoke can cause or worsen a number of respiratory diseases, including lung cancer, asthma, and there is no safe level of exposure to secondhand smoke. Secondhand smoke is a serious public health problem, and the statistics are startling. Secondhand smoke causes approximately 7,330 deaths from lung cancer annually, and 33,950 deaths from heart disease. As I said, there is no risk-free level of exposure, and even short-term exposure can potentially increase the risk of negative health impacts. Additionally, while secondhand smoke is yet to be established as a known risk factor in developing more serious COVID-19 symptoms, many of the underlying conditions caused or made worse by secondhand smoke are potential risk factors. Smoking in confined spaces can also compromise the use of face masks, since someone would need to take the mask off to smoke, which could contribute to the further spread of COVID-19 when a smoker exhales. No one deserves to have to choose between their transportation needs and their health. Thus, the American Lung Association urges you to support LD 269 to help clarify that Maine's popular and strong smoke-free public places law include bus shelters.
Thank you. Questions from the committee for Mr. Bushy? Seeing none, I believe that concludes our testimony on this bill. It does. Information, additional information from the committee for the work session. It looks like we've got everything that we need. So I will close the hearing on LD 269. Thank you very much for your testimony. With that, we will open up the hearing on LD 38, an act to clarify the timing of an appeal of a finding regarding involuntary mental health treatment as a designated non-state mental health institution, presented by our own Senator Ned Claxton. Senator, you are on mute.
I'm a rookie on this end of the mic. Thank you, Chair Meyer and respected colleagues on the Joint Standing Committee on Health and Human Services. My name is Ned Claxton, and I'm proud to represent Senate District 20, consisting of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. I'm here introducing a departmental bill, LD 38. I won't repeat the title that Chair Meyer read because it doesn't roll off the tongue, but it relates to involuntary treatment, which means that there's a clinical recommendation for therapy for some sort of treatment, but the patient refuses to accept the recommendation. And there are certain circumstances where it's approved to provide the patient with therapy, even though they're refusing. And there's some steps that have to go through and some appeals process before you can get to involuntary treatment. As I understand the bill, it impacts only two institutions, Northern Light Acadia Hospital and Spring Harbor Hospital. And it involves changes to the review criteria that DHHS would use on the appeal review, and it changes the time frame for ruling on the appeal. This is obviously not something I'm not particularly familiar with, so I defer to the experts from the department to explain their thinking. I thank you for the opportunity to introduce LD 38.
Thank you, Senator. Here to provide testimony for the department is Mr. Joseph Pickering. Mr. Pickering.
Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Joseph Pickering. I'm the Chief Administrative Hearing Officer of the Division of Administrative Hearings in the Department of Health and Human Services. I'm here today to introduce and speak in support of LD 38. The department is grateful to Senator Claxton for sponsoring this bill on our behalf. LD 38 seeks to amend 34B MRS Section 3861 to clarify the process for appeals of involuntary treatment orders from clinical review panels at designated non-state mental health institutions, for example, Spring Harbor Hospital or Northern Light Acadia Hospital. More specifically, LD 38 would clarify the standard of review and extend the deadline for DHHS to issue a decision on such appeals. Involuntary treatment, that is medication, can be ordered by a clinical review panel at a designated non-state mental health institution. The patient can appeal the clinical review panel decision to DHHS. The statute currently states that a decision on the appeal should be issued within 3 business days, but does not specify what standard of review should be used by DHHS in reviewing the order of the clinical review panel. Appeals at DHHS of clinical review panel decisions are generally handled by the Division of Administrative Hearings, with the Commissioner retaining final decision-making authority. The Administrative Hearing Officer conducts an evidentiary hearing and issues a recommended decision, and then the Commissioner issues a final decision accepting or rejecting the recommended decision. When the Division of Administrative Hearings conducts such an appeal, it currently does so on what is called a de novo basis, requiring testimony by witnesses. There are, however, significant practical difficulties in scheduling a hearing, holding a full evidentiary hearing with testimony, reviewing materials submitted by the parties, issuing a recommended decision, and having the Commissioner issue a final decision within 3 business days. It is not clear that the legislature actually intended appeals to DHHS of clinical review panel decisions by non-state mental health institutions to require a full evidentiary hearing. The statute does not specifically state that the Commissioner must hold a full hearing. The clinical review panel process conducted at the non-state mental health institution is already a form of hearing. The statute allows for appeals of clinical review panels at state mental health institutions, that is Riverview Psychiatric Center and Dorothea Dix Psychiatric Center, to go directly to the Superior Court without an additional administrative hearing at DHHS. The purpose of having appeals to DHHS of orders of non-state mental health institutions' clinical review panel appears instead simply to be a necessary procedural step to allow the patient the opportunity to appeal the Commissioner's final decision as final agency action to the Superior Court under Rule 80C of the Rules of Civil Procedure. The intent of this bill is to resolve this issue. The bill clarifies that DHHS should simply review the order and record that was created by the clinical review panel. The bill establishes a standard of review where the Commissioner or the Commissioner's designee would review the decision for abuse of discretion, error of law, or findings not supported by substantial evidence in the record. This is the same standard that the Superior Court uses in reviewing final agency decisions. The bill also establishes deadlines for the designated non-state mental health institution to submit the record to the department and for the submission of written arguments by the patient and the institution. This will clarify what actions each party must take. I would note that designated non-state mental health institutions are well aware when a patient appeals, because since the patient is restricted to the institution, it is the designated non-state mental health institution that notifies the department of the appeal. Finally, the bill extends the deadline for the Commissioner to issue a final decision to 4 business days after the submission of the record and any arguments. This ensures that the Commissioner or the Commissioner's designee has a more reasonable opportunity to review the record and any objections before issuing a final decision. In conclusion, the current appeal process is not practicable. This bill provides much needed clarity regarding the standard of review for appeals from clinical review panel orders at designated non-state mental health institutions, and slightly extends the deadline to allow DHHS a more reasonable opportunity to conduct a review and issue a final decision. I look forward to working with the committee on this bill and will provide further information if necessary. I'm happy.
Thank you, Mr. Pickering. Questions from the committee? Yes, Representative Javner.
Thank you very much, Chair Meyer. So I have a question, Mr. Pickering, concerning the department's designee or the commissioner's designee. Historically speaking, who has that designee been in the department during this process? Well, if it hasn't been the commissioner.
There hasn't been. With the most recent version of the statute, what our process has been is that typically the hearing officer does the recommended decision and the commissioner has done the final decision. I believe under previous versions of the statute, it would have been the head of, well now, which is the Office of Behavioral Health, or the head of Substance Abuse Mental Health Services, you know, in the past. But currently, it's just been the commissioner. You know, I think some of the thoughts are that perhaps it could be myself if I were, you know, if the commissioner chose to pick a designee, but it's always been the commissioner, and she's always retained final decision-making authority regarding these types of cases.
Thank you very much.
Representative Craven.
Thank you, Madam Chair. Does this include involuntary admissions as well? Is this the process that would be used?
I'm sorry, I'm not sure if I quite heard you, but involuntary admissions, no, that's a process under the district court. So this is just, these patients that we're talking about have already been involuntarily admitted to the hospitals, and then the hospitals are seeking the involuntary treatment. So they've already been committed.
Senator Claxton.
I don't expect you to have this handy, Mr. Pickering, but I'd be interested for the work session in knowing how often this appeals process happened per year by institution.
Well, I can tell you that in the past year, I would say that we've had 4 appeals, and they seem to be increasing. That's the reason why we sought to bring this bill. I've been the Chief Administrative Hearing Officer for 2 years now, and when it first came up was about a year ago. The year before that, we hadn't had any, and I mean, hadn't had any for a long time. And when this initially came up last year, when we were talking about the process, everyone had a hard time thinking of when the last time we had one. But basically, it's a process that's now being used, mostly by Northern Light Acadia, and they've been using it frequently.
Thank you.
Senator Baldacci.
Thank you, Joe. It's good to see you. I wanted to ask Mr. Pickering, if are these primarily used when the patient is refusing medication? Are these used for medication treatment cases where, you know, in order to administer a medication that they're refusing?
Yeah, it's only when they've been refusing medication. It's my understanding that the institution doesn't seek one of these orders unless the patient is refusing to engage in medication.
Okay, and you said this was there were 4 of these last year or something?
In the past year, there have been 4.
Okay, and this bill is really just to clarify the process to make sure there's due process. I mean, I don't see anything nefarious in it either way. I mean, I'm assuming this is pretty much to ensure that this is an orderly process in terms of the judicial review or the administrative review of this. Is that a fair statement, or?
Well, I think so. It's more to, I mean, to make it, it's more dealing with the tight deadlines. You know, as I mentioned before, our 2 major concerns. One is that it's not clear what standard of review we should have. Should it be a de novo? Should it be, you know, a more lenient standard similar to what the Superior Court uses? And that's certainly been an issue in the hearings. The hospital has brought up. But then, the more critical issue is that it's just so difficult to schedule and hold a hearing within 3 business days.
Right.
I think that makes it hard in terms of making sure that enough time is being taken to make to given a reasonable opportunity to issue a well thought out decision on whether or not the hospitals follow the appropriate criteria. So I don't think that it changes the due process. Quite frankly, it's more of that the deadline is just extraordinarily difficult to meet.
Yep. No, that's, I read it, it did not change substantive rights. It was more to deal with the procedural issue.
Oh, absolutely.
Yeah. Thank you very much, Mr. Pickering.
Thank you.
Representative Zager.
Thank you, Madam Chair. I had a couple of questions, but Mr. Pickering, you already answered one of them in your response to Senator Baldacci. The other is regarding the makeup of the review panels and how many people are on the panels?
3. The clinical review panels occur at the hospital. We're reviewing the decision of it. So, but the clinical review panels have 3 people, and they are either psychiatrists or psychiatric nurses. Persons who administer, who can prescribe medication.
Okay, thank you.
Additional questions from the committee? Seeing none, requests for additional information for our work session.
Thank you.
Thank you, Mr. Pickering. Up next, testifying in against the bill is Mr. Jeff Austin.
Let me get closer so you can see me. Good afternoon, Representative Myers, Senator Claxton, and members of the committee. With your indulgence, I'd like to speak in opposition to the bill, but it's going to take me a few minutes to get you to where we are in the process. And this is very important for you to hear how we got to the stage of this patient's life that we're at. And with that background understanding, I think you will understand our concerns with this legislation. To Senator Baldacci's point, I don't think there's anything nefarious going on either, but we do have some significant concerns, and I'd like to explain them to you, and my colleague, Lisa Harvey McPherson, will fill in as well. So you're dealing with someone who has been involuntarily committed to one of 2 private psychiatric hospitals. There are 4 psychiatric hospitals. DHHS operates 2 of them. Northern Light operates 1 in Bangor, Acadia. Maine Health operates 1 in Portland, or Westbrook, Spring Harbor. But the path there is very important. The typical fact pattern is someone is picked up, maybe by police, brought in by family to your community hospital. I live in Brunswick. It's apparent that they're suicidal, homicidal, they're an immediate risk to themselves or others. In those situations, the law allows the community hospital to hold the patient and transfer them to a psychiatric facility. It's called the blue paper process. You may have heard of it. It's temporary emergency hold and transfer. Once that occurs, the receiving hospital, Spring Harbor or Acadia, has, under the law, 14 days to get to district court to hold the white paper commitment hearing. That's the formal hearing to extend the stay at the psych hospital. Crucial to that and central to that process, which you need to understand for this bill, is that the courts hire independent clinicians called examiners to examine the patient and make a recommendation to district court should this patient actually be committed for a stay at the psychiatric hospital. As part of that white paper process, and I've laid all this out for you in my written testimony, and I've also given you the 2 statutes at the end of my testimony. As part of that process, the statute requires the examiner, where appropriate, to consider the issue before you, involuntary treatment. which is medication, and make a recommendation to the court. So the nub of our issue is that's happening in Portland for commitment hearings down there. It is not happening in Bangor, and I'll explain why in a minute. So if the patient was sent to Portland, the examiner would consider the issue of involuntary medication, make a recommendation to the court, and the court, let's say they agree, they make a commitment order and an involuntary treatment order. As I understand it, this is all secondhand, and the process is essentially over. Patient is now at Spring Harbor, Westbrook, being treated. Took about 12 to 14 days. 1 or 2 days for the blue paper, 10 days for the white paper. Fairly extended period of time. It's important that you know that. What happens in Bangor? The law lays out for you a secondary process to get to involuntary treatment. And that's what Mr. Pickering explained. The receiving hospital, in this case Acadia, is authorized to create a clinical review panel, a little mini internal court, where they review the issue. Should there be involuntary medication treatment? That takes about 2 or 3 days. The patient has the right within 24 hours of that decision to appeal to the commissioner of the HHS. So 1, 2 days blue paper, 10, 12 days white paper, 2, 3 days clinical review panel. Now it's being appealed. Now we get to the bill. That 15-day pre-period is important for you to understand as you consider whether to stretch this out any further. You're at 15, 16 days without treatment, potentially. You know, there are emergency abilities. The bill in and of itself does 2 things. The first of which we probably agree is rational and reasonable. The second one we do not. The first change of creating a 3-day argument period does not exist now. I don't know that we need a 3-day argument period, but for the benefit of the individual, giving them a 3-day period, I think we can understand that. But we believe at the very beginning of that 3-day period, as part of the appeal, the department will be receiving the full record to that point. The white paper analysis, the clinical review materials, they should have everything at the beginning of that 3-day argument preparation period. Then the argument will happen. The second thing this bill does is give the department 4 days to make a decision. That's the part we do not think is reasonable. That should be done. This patient is now at day 19 or something. So that second period where they've had the record for 3 days, now they've had the argument, let's make a decision. So at the very end of my testimony, that's the first request. If you're going to add a 3-day prep period for the benefit of the patient, understood. But 4 additional days, as I'm reading the bill, if I'm wrong, I'm wrong, but it looks like they get 4 days to deliberate and make a decision. Sorry about the lighting in my house here today. We don't think it's reasonable. But the second request we have at the end of my testimony and before the, I think, 7 pages of statute that are relevant here is what's going on with the examiner situation. And my colleague Lisa, I think, can speak to that more directly. And so while there are not many cases, these are 3-4 week, 15, 20-day situations. So they're pretty serious and significant, even though thankfully they're not common, but they are regular. They happen regularly. So if I was in the department seat, I would want something like this bill, a little bit more time to get things squared away. Very understandable. But we wanted you to have this background, and I appreciate you not putting me on the normal 3-minute clock, so that you can understand the 18 days that went into getting to this point. So again, my colleague Lisa can answer probably questions as well, but with that, I'd be happy to take any questions. And I've tried to lay this out to you in my written testimony. Thank you.
Thank you. Questions for Mr. Austin? Seeing none. Next up is Lisa Harvey McPherson. Welcome, Ms. Harvey McPherson.
Thank you. Good afternoon. Good afternoon, Senator Claxton, Representative Meyer, and committee members. My name is Lisa Harvey McPherson, and I'm here today to speak in opposition to this bill on behalf of Northern Light Health, specifically Northern Light Acadia Hospital. Jeff did a great job laying out the process, so I will speak specifically to Acadia Hospital. Up until a few years ago, that independent examiner process that is described for Spring Harbor was also available to Acadia Hospital. So all of those decisions flowed through district court. But when Northern Maine lost their independent examiner, Acadia was in a position to set up these internal clinical review panels for purposes of evaluating a patient that was involuntarily hospitalized to determine medication recommendations. And then Mr. Pickering described the process of an administrative hearing and then a commissioner's decision. The core root of this problem isn't the clinical review panel. It's restoring the independent examiner to Northern Maine. So we are in discussion now with the Attorney General's office and the judicial branch on restoring that service via telemedicine technology. So the examiner that's available in Southern Maine could be available to Acadia Hospital about 4 times per year and perform this function. That really is the solution to this process. But if we were to take a look at the bill, it wasn't clear until Mr. Pickering testified. We were not clear that the department's goal was to eliminate the administrative hearing that exists today. So the clinical review panel makes a recommendation. Our legal team turns around that information to the department in one business day. And then there's an administrative hearing, and then of course a commissioner decision. So the change that is important in this bill, from what I understand from his testimony, is we would submit records to the department, and we turn that around in one business day. And very often the patient wants to appeal, and they have the right to appeal, but there are advocates who help them. And so the advocates become involved. That can take a day or two. That's why I can agree, as Jeff said, to the 3 days that are in the bill. But once all of that information is presented, we believe that the commissioner should turn around their decision in one business day. We should not have these patients languishing in our hospital without treatment any longer. That relates to the bill, but that's not the real solution. As I said, the solution is having that independent examiner make themselves available by technology to Acadia Hospital. So our request of the committee really is to ask the department to do what they can do to facilitate the discussion we're having now with the AG's office and the judicial branch to make that happen. That really solves the problem. And with that, I welcome any questions that you have.
Thank you. Questions for Lisa Harvey McPherson? Yes, Representative Stover.
Hi, Lisa. Thank you very much. I just had one question, both listening to all 3 of you. It sounds like the issue is with the particular, it's a process change, that there's no opposition to involuntary commitment or medication in a psychiatric emergency. It's the opposition, the problem with this, as you see it, is with the availability of the independent examiner in the timely way.
Mm-hmm.
Okay, I just wanted to clarify, and thank you for that.
Any other questions for Lisa? Yes, Senator Claxton.
So when you had, Ms. Harvey McPherson, when you had an independent clinical examiner, they can't be on full-time payroll. They must be on a per diem basis or something if you're going to have 0 to 4 times a year.
Mm-hmm.
Is that true?
Correct. And they're not on our payroll, but they're funded and they're called a referral would go to them for this type of evaluation.
Okay, and so that, given the fact that there's virtually none that come out of Spring Harbor that we hear of, that would leave that person pretty available to you, should you need that person.
That is the discussion that we're having with the Attorney General's office and the representatives of the judicial branch. We believe that the workload can be accommodated. And the discussions are going well, from what I understand. So we just want to move them along.
How long have these discussions been going on?
I think, I don't want to misspeak.
That's okay.
I can get a definitive timeline. I don't think it's been an extended, oh dear God, we can't get anywhere type of discussion. I think they've been moving along.
And the independent clinical examiner is somebody who must have another job or does this recreationally.
I would think so. I don't know who the clinical examiner is. I could get that information, but what's important is they have the clinical skills and the prescriptive authority to make this level of recommendation.
Thank you.
Representative Stover, is your hand back up or still up? Any other questions? Seeing none. Requests for additional information for the work session from the committee. Seeing none, I will close the public hearing on, yes, Representative Javner.
Sorry, I really just am very interested in knowing the reasoning why there has been an uptick recently in the numbers. And we don't need to answer that today. We can answer that during the work session. Thank you.
Okay, thank you. Seeing no other hands up, I will close the work session on LD 38 and open the work session on LD 450, an act to promote the education of parents by primary care and urgent care physicians regarding the bone marrow transplant list, presented to us today by its sponsor, Representative Margaret Craven.
Thank you, Madam Chair. Good afternoon, Senator Claxton, Representative Meyer, and fellow members of the Health and Human Services Committee. My name is Margaret Craven and I represent House District 59, which is part of Lewiston. I'm pleased to be with you today to introduce LD 450, an act to promote the education of patients by primary care and urgent care physicians regarding the bone marrow transplant list. And I bring this bill forward on behalf of Team Up Cancer. The bill before you will require the Department of Health and Human Services to develop, and I'm guessing now that it's CDC actually, because we got a letter this morning from the CDC, to disseminate the information and educational materials regarding bone marrow donation in coordination with the National Marrow Donor Program to both the public and healthcare providers. Bone marrow transplants can treat many diseases, and for some diseases, they're the only potential cure. Diseases treated by bone marrow transplant include some forms of cancer like leukemia and lymphoma, but unlike information on how organ donors or blood donation can be processed, there is significantly less awareness of how to become a bone marrow donor. The information is out there, but it is not as widely circulated or promoted. According to Be the Match, which is operated by the National Marrow Donor Program, only 2% of Americans are registered bone marrow donors, and approximately 30% of all bone marrow donors come from family members, which leaves 70% of all donations coming from non-family members. Patients with specific life-threatening illnesses depend on the general public knowing about bone marrow donation, what is and what it entails, and the process to sign up to be a donor. 3 states have already passed similar laws: Missouri, Illinois, and New Mexico. And I thank you very much for your time and consideration, and I'd be happy to answer any questions. In my younger days,
Thank you, Representative Craven.
I was actually a donor, although I've been kicked off now because I'm too old. But it's certainly is a life-saving process.
Thank you for that testimony. Questions for Representative Craven? Seeing none, we will move to Rico Dents, who is testifying in favor of this bill. Welcome.
Good afternoon, wonderful people. How are you all doing today? Thank you, Representative Craven, for introducing the bill. I asked you to do that and really appreciate it. And fellow survivor, yay. I have chronic myeloid leukemia, and this is what kind of led me to doing this. When I was in high school, I heard a testimony from one of the pastors that I knew, sharing that he had no chance of survival. And at that time, and it was in like 1976, I didn't know the full extent of his story, that he was some of the first people to receive a bone marrow transplant. He died last year, actually in 19, in December. So he was able to live basically 40 years, a little bit longer than 40 years, by receiving a bone marrow transplant. And I've heard other people's stories. Who knows what a peripheral blood stem cell transplant is? Okay, more than the average. And why I asked that question, this is the whole point. It has been around since 1986, a peripheral blood stem cell transplant. And that's a difference from doing a bone marrow transplant versus doing a peripheral blood stem cell transplant. And what that is basically you're injected a drug called filgrastim for about 5 days. And then on the 5th day, you sit down for about 2.5 hours to 3 hours, where they put an IV and they just weed out 3 to 5% of your cord blood stem cells. It doesn't even affect you. You won't even notice it, but it makes a major difference in helping to save a person's life. At any given time, 7,500 people are looking for a match. Less than half ever find a match. And people are saying, well, what about the family members? Well, 70%, 7 out of 10 of all matches come from non-family members. And you know that famous country, Germany? They actually per capita donate more bone marrow than the rest of the countries around the world per capita, because like the doctors, and they put it in the high school education about the bone marrow registry. So they're aware of it. Here in the United States, we're just not aware enough of it. It is 2% of Americans are registered bone marrow donors. And so it's just something that we could do that costs nothing to the state, costs nothing to the doctors. And the doctors could, I'm trying to get EPIC, which is out of Madison, Wisconsin. They do like the doctor, all that intake forms and other stuff, and a couple of the other software companies that do the medical intake, trying to get them to add that question even into that medical intake form to help streamline all of this process. So this is something that will help save people's lives, and at the same time, really costs nothing for the state. So it's a win-win for everyone.
Well, thank you. Thank you for your testimony. Question? Yes, Representative Craven.
Thank you. I did get a fiscal note, actually. The CDC would have to hire somebody to process the information. I think, I don't have it in front of me, but I think I remember it's like $179,000.
That's the highest in any other state. A lot of them say not more than even $5,000.
I just wanted to make sure that people knew, what the fiscal note was, because our OFPR office sent that forward. Thanks.
Thank you, Representative. Any other questions for Mr. Dents? Seeing none, thank you so much for being here today. Oh, no, I do see Representative Zager.
Thank you, Madam Chair. Actually, I just wanted to, I had an information request for the work session, but I do appreciate, Mr. Dents, you coming today. I'm so glad that you have fared well after treatment. So thank you for coming today. Madam Chair, would you permit me to make the request for the work session now?
Absolutely. Go ahead, Representative.
I'd be interested to know what's, if there are any other states or health systems where there's a systematic way, as Mr. Dent brought up, perhaps having in an electronic medical record as part of a routine intake, where this is done, how well it works. Because there might be a lot of people who are giving blood for blood tests while they're in the hospital for a hip replacement or what have you, who would love to be bone marrow donors in a registry. And perhaps if there was a way that information could be collected with their consent and then followed up on by the national bone marrow registries, that might be a way to elegantly and without costing the state money achieve better outcomes in health.
Go ahead, Mr. Dents.
Within that, basically, there's only so many people who donate blood. A lot of people, there's only percentage, and I know a lot of different states already coordinate that, and depending on the states, they do coordinate letting people know about the bone marrow registry or actually regular donors. People are scared to give blood because they have not done it before. So I don't know what the percentage of the population that actually gives blood. There's a little bit of a different process than giving blood. Another thing is 5 states have passed legislation: New York, New Mexico, Illinois, Missouri, and Nebraska. And the implementation, double checking everything, hasn't been completely processed. 1, we're not funded as an organization. 2, I don't know how. And I figured as we got more states, then I have a lot of college interns. I have about 40 college interns. We're going to start working on that. I talked to Be the Match just recently this week in how do we start helping to implement it and seeing the response. But the other thing that we sometimes forget, it takes in anything 6 to 8 times before someone responds to anything, like in the basic marketing and business and life. And so the people need to hear about 6 to 7 times to 8 times about the bone marrow registry before they actually get registered. So even it is way cheaper than spending the money on marketing on a regular basis, because that cycle switches. It's cheaper because it goes to the doctors can provide the pamphlet, and Be the Match will provide the pamphlets at no cost. And it's just something, because people trust medical doctors and nurses and stuff like that. The nurse could share it. It's just getting them to get that one of those 8 times, so before they could start moving forward and becoming donors.
Thank you. Representative Madigan.
Thank you, Madam Chair. Mine's a request for information both from Mr. Dents and for the department. There seemed to be a difference of opinion on what a fiscal note should be. Mr. Dents, you referred to in other states that it wasn't as expensive, to implement a program like this. So if you could bring that information to us to our work session, and if the department could kind of explain how, or someone could explain how they arrived at their fiscal note, I think that would help us kind of hash that out. Thank you.
Thank you. Any further requests for information for the work session? Seeing none. Thank you so much for being here. And hopefully we'll see you at the work session as well. And I don't see any further, anyone else in the waiting room to provide testimony on this bill. And with that, I will close the hearing on LD 450 and turn to our analyst, Erin Dooling, to see if we've got anything else on our schedule today.
We don't really have anything else on our schedule unless there were members of the committee who felt moved to present on the reports they had signed up.
Anyone volunteering? I see Representative Perry has her hand up. So we will let you take it away as soon as you unmute yourself.
There we go. Okay, the report I'm going to report on is the Acquired Brain Injury Advisory Council of Maine. I had the pleasure of having it last year, so this is another one. Just a little bit about the Acquired Brain Injury Advisory Council of Maine. First of all, just informationally, every 9 seconds, someone in the United States sustains a brain injury. Pretty significant. An acquired brain injury is an injury that occurs after birth and is not hereditary, congenital, degenerative, or induced by birth trauma. That covers a whole lot of area, actually. The Advisory Council was formed in 2002 with the support of a federal grant, and then was established by statute in 2007 to provide oversight and advice to DHHS and the legislature. And over the past 14 years, I'm going to put ABIAC, it's easier, has served as a mandated advisory board for 4 federal traumatic brain injury partnership grants to improve Maine's system of care for persons living with brain injuries and their families. In 2020, the council met 10 times and held 2 public hearings, even through the COVID. I guess a lot of that was done by virtually. Okay, so currently, through a federal TBI partnership grant, the administration of the community living has made great progress in 2020 on tackling the intersection of brain injury and the opioid crisis in Maine. And I almost thought I would do the priorities for 2020s and outcomes, but I'm not going to. Those are ongoing and they show up in the 2021 priorities. So for 2021, the priorities that the Advisory Council on Brain Injury, Acquired Brain Injuries, one is to advocate for the development and funding of neurobehavioral treatment services, 24/7 care to ensure humane and cost-effective evidence-based treatment in Maine. And 2, to advocate for state law clearly describing the rights of service recipients with acquired brain injury. 3, to advocate for ongoing coordination and funding for services to address the confluence of persons with substance use disorder and a brain injury. 4, to improve access and impact of assistive technologies, telehealth for service recipients and providers through an advocacy for DHHS rule changes that provide greater flexibility. And 5, support the creation of an acquired brain injury trust fund to help Maine children and adults with acquired brain injury who lack financial resources, eligibility for timely, effective treatment. Next, improve understanding and coordination of services for children with acquired brain injury through regular participation of a representative of OCFS on the Acquired Brain Injury Advisory Council. And 7 is to improve effectiveness of the ABIC through providing advanced formal quarterly status reports describing critical indicators of brain injury services from ODES, Maine Care, Maine CDC, and OCFS, and to provide guidance to the ACL partnership grant efforts, including a statewide needs assessment to be conducted in 2021. That's a summary of what they are looking at doing for 2021. And actually, it will be interesting to see how the needs assessment that they're doing in 2021 actually comes out.
Thank you, Representative Perry. Anyone have any, well done. Anyone have any questions or comments for the representative? I think we're seeing some legislation that's coming in front of us maybe soon.
Yeah, I don't have the LD in front of me, but it's related to the rights of recipients.
Exactly. Yep. Representative Hepler's bill, I believe. Okay. Anyone else volunteering a report this afternoon? Seeing no takers, and with nothing else on our agenda, I would entertain a motion to adjourn.
So moved.
Second.
Second.
All in favor? See you Monday.